So CAR T for CLL was just recently FDA approved, maybe about a year ago, a little bit less than a year ago in the US, and that approval was based on the TRANSCEND-CLL-004 study, which is a phase 1/2 trial of relapsed refractory CLL patients who had failed at least 2 prior lines of therapy, including BTK inhibitor. Everybody needed to have had a BTK inhibitor. And we treated about 118 patients with liso-cel CAR T cells, the Lisocabtagene maraleucel CAR T cells on this trial. And we found that out of 88 or so efficacy evaluable patients, the complete remission rates were about 20%. And this was the same for patients who had actually failed both BTK inhibitor therapy and BCL2 inhibitor therapy, so the particularly bad acting CLL patients. And so with a CR rate of 20%, a sort of an deep, undetectable minimal residual disease rate of about 67%, we thought that these particular patients got a lot of benefit because they had had a median of 5 prior lines of therapy, and once they were in CR, they still haven't relapsed. Now we're up to a median of 3-year follow-up. I've had patients now 5 years on the study who have not relapsed. So certainly there's a benefit for that patient population. And so the FDA approval came for the double refractory patient indication, if you will. So having failed both BTKI and BCL2 inhibitor therapy. I think the second part of your question about where this fits in and which patients we can choose this for really is for the patients who are double refractory, but then also maybe before they fail too many lines of therapy, because sooner we can give this with the least amount of disease, the better we think the outcomes might be. We've shown that in post-hoc analyses that the CR patients were the ones who had smaller disease, less rounds of prior therapy and things like that. So I think less bulky disease and less prior therapies would be what I would choose for would be when I would choose CAR T cells for my patients.